Hello everyone. Thank you for joining us for this virtual poster competition. Today I would be presenting our research project that explores serum procalcitonin level in patients with COVID-19 pneumonia. This project was possible due to combined efforts with my co-resident Dr. Bass and guidance from Dr. Lidner. As we navigate our way during this pandemic through the many unknown variables surrounding this COVID-19 virus, a question that comes to mind is there any correlation between procalcitonin level and COVID-19 pneumonia? And if so, is there clinical utility of ordering this test for these patients? Procalcitonin, which is a precursor of calcitonin, was first noted to be elevated in 1993 in patients with sepsis and infection. Its production is linked to bacterial endotoxins as well as inflammatory cytokines such as TNF, IL-1B, and IL-6. It has been noted that its levels are not elevated in viral respiratory infections. This allows for its use in predicting whether respiratory infections are of bacterial or viral etiology and also to de-escalate antibiotic therapy. However, since COVID-19 is a severely inflammatory virus, there is a knowledge gap surrounding its level in these patients. So we conducted a single-center retrospective study reviewing charts of patients who presented between April 11th and May 18th earlier this year. The inclusion criteria were males and females over the age of 18 years who had presented to the hospital and met the criteria for COVID-19 testing by RT-PCR set forth by CDC and who had a documented procalcitonin level results during the hospitalization. Those who were excluded were patients under 18, trauma patients, burn patients, those with end-stage renal disease, intracranial hemorrhage, or even pancreatitis. Vulnerable populations were not included. Patients were then categorized into one of the four groups, Group 1 being both COVID-19 and procalcitonin positive, Group 2 being COVID-19 positive, procalcitonin negative, Group 3 being COVID-19 negative, procalcitonin positive, and Group 4 with both COVID-19 and procalcitonin levels to be negative. For the purpose of this study, a procalcitonin level of 0.25 or greater was considered positive. So out of the 243 patients analyzed, 150 of them tested positive for COVID-19 and 93 tested negative. If I could draw your attention to the table at the bottom right of the poster, of those patients who tested negative for COVID-19, 37.3% had a positive procalcitonin level and 62.7% had a negative procalcitonin level. Of those who were positive for the disease, 15.1% had positive procalcitonin level and 84.9% of them had a negative procalcitonin levels. And based on odds ratio, a negative COVID test result and procalcitonin level greater than 0.25 is 3.4 times more likely than a positive COVID test result and procalcitonin level greater than or equal to 0.25. This association was demonstrated to be significant with p less than 0.001. This indicates that despite the known inflammation caused by COVID-19, the low procalcitonin demonstrated here is consistent with the procalcitonin levels in other viral respiratory infections. It is a readily available, quick and inexpensive test, and there is clinical utility of ordering it. A procalcitonin level of more than 0.25 would be suggestive that the patient would most likely test negative for COVID-19, and this information can be used for pursuing other etiologies of lower respiratory tract symptoms, thereby helping us avoid the anchoring bias during the current pandemic climate. And I invite you to read our full article at ResearchGate using the QR code at the bottom right, and thank you for your time.